Good morning to you all, and welcome to the sixth lecture of the 2019 Palliative Care Lecture Series. Hospice New Zealand would like to thank you and acknowledge Cancer Research Trust New Zealand for their generous support and funding to deliver these free lectures. The lecture today will be recorded, and it will be available on the Hospice New Zealand website. Please be aware there will be an opportunity for questions at the end of the presentation. We would now like to introduce our guest speaker today, Dr. Sinéad Donnelly, Consultant Internal Medicine at Wellington Hospital and Senior Clinical Lecturer and Module Convener for Palliative Medicine at Aotearoa School of Medicine, Wellington.
Atemari, G. Vermagin. He aha te maia nui Aotearoa, he tangata, he tangata, he tangata. So I'm presenting today an update on the euthanasia bill in New Zealand. Last year, I would have presented the detail of the bill, and many of you may remember that, with a medical and legal analysis of the bill clause by clause, which I'm not going to repeat, but rather this is an update. On the 13th of December 2017, David Seymour's End-of-Life Choice Bill, which is for euthanasia and assisted suicide in New Zealand, had its first reading in Parliament, in the New Zealand Parliament. It was voted in favour by 76 votes in favour and 44 against. It was then sent to the Justice Select Committee, which reported back on the 9th of April 2019, and I'll refer to the Justice Select Committee later. At that time, the 2 points that were made in the document from the Justice Select Committee were that in its present form the bill was unworkable, and secondly that they couldn't all agree in the Justice Select Committee. Many of you will have submitted to the Justice Select Committee, and some of you may have presented orally. On the 26th of June 2019, the bill came before the House for its second reading, and it was passed 70 votes to 50. So I'm just going to go through a synopsis of the bill just to remind you. The regime set out in the bill is straightforward, with very few checks between a patient expressing a wish to have the option of assisted suicide and the administration of the lethal drug. And assisted suicide in this refers to euthanasia as well. The regime is predicated on the basis that once an eligible patient has expressed this wish, then the relevant medical practitioners are obliged to follow a process which has the sole aim of facilitating that patient's euthanasia or assisted suicide. In summary, the person expresses a wish, then a request form is completed. Eligibility is determined and checked by 2 medical practitioners, the second of which must be from the SCENZ, which is SCENZ, list of practitioners who are all supportive of assisted suicide. They each complete a form. That's the 2 doctors. A time and method is decided, and provided the appropriate forms have been completed, the lethal drug is administered. Once the request form has been completed, as I said, the patient's eligibility is assessed. The eligibility criteria are critical to this regime, as once a patient is assessed as eligible, there are no further stop points for their protection. The eligibility criteria are broad, creating an essentially on-demand availability of assisted suicide for patients with any significant physical or mental disability or chronic illness, including mental illness or terminal illness. The bill requires only that the person be over 18 and a New Zealand citizen or permanent resident, has either a terminal illness that is likely to end their life within 6 months, or a grievous and irremediable medical condition which is not well defined. They have to be in an advanced state of irreversible decline in capability. Again, this is not well defined. And they self-assess that they experience unbearable suffering, and the unbearable suffering is not defined, that cannot be relieved in a manner that he or she considers tolerable. I suppose that's a slight definition. The person has to have sufficient mental capacity simply to understand the very simple proposition that assisted suicide will end their life. The breadth of the eligibility criteria means that any medical practitioner in any scope of practice who is dealing with a person with a serious disability or chronic illness, who is told by the person that they wish for assistance to end their life, is obliged to facilitate that request or facilitate referring them on to someone else who will do so. The bill requires a second opinion, as I've said, from a SCENS nominated practitioner on whether the set eligibility criteria are met. That is all that the second doctor has to do. And the SCENS group is to maintain a list of doctors willing to act to facilitate assisted suicide. So, having passed the second reading, the bill now goes to the Committee of the House. At this stage, there is expectation they will introduce amendments or supplementary order papers. And that will begin by the end of July, once the recess is over and the next Members' Day occurs on a Wednesday at the end of July. There's one other, I think, bill ahead of this bill. It is possible that the third reading could be in September. These are how the MPs voted. The phrase AYES means yes. So there's actually two doors within Parliament, because I sat for the debate this time and also in December in 2017, two doors, and those who are voting yes walk through one door, and those who are voting no walk through the other door. So these are the Labour MPs and the National MPs who voted yes. The underlined name are those MPs who changed their vote from the previous reading or the previous first vote. So Poto Williams changed from voting no to voting yes. Judith Collins and Lawrence Yule changed from voting similarly. Now, Lawrence Yule has, with Louisa Wall, who's a Labour MP, come up with a supplementary order paper, a suggestion of involving the family court. It still involves doctors giving the injection, ending the life of the patient, but in order to perhaps introduce a new safeguard, it would have to go through the family court. This has been discussed within Parliament in small group panel sessions, and I understand that people can see problems with this already. These are the MPs, Labour and National, who voted against the bill, and there are 50. Again, underlined are those who changed their vote, that is from yes to no, since the first reading. Are the next parties, the Green Party in New Zealand First. The Green Party has a policy in favour of euthanasia. So although this is a conscience vote for a private member's bill, David Seymour's bill, they're voting en bloc. They voted this way, the first reading and the second reading. New Zealand First are voting en bloc also, and we understand that's because they have agreed with David Seymour that they hope for a referendum, so that if it's passed at the third reading, it would then go to a referendum which will occur during the general election of 2020. Andrew Little, who is Minister for Justice, has said that any bill that is to go for a referendum in the general election of 2020 must have been passed by March of 2020. So that's the timeline. So this is the response of the Care Alliance. Now, I'm the Deputy Chair of the Care Alliance. I'm also initiated the collection of signatures of doctors, which we'll refer to in the Doctors Say No. So that's my background. You're well aware by now, and I suppose perhaps how I'm speaking and having heard me before, that I'm opposed to this legislation for all the reasons outlined by the different organisations that I'll present. So this is how the Care Alliance responded to the passing of the bill at the second reading. The gap has been narrowed. That is, the difference between the yes and no MPs has got smaller by 6 votes. We are confident that during the committee stage, which is the next stage, even more MPs will realise that the bill places vulnerable people at risk and that public safety cannot be assured. We note further that this was meant to be a conscience vote, not a party vote, and yet all 17 members of the Green and New Zealand First parties voted in one direction only. We call on them to move away from block voting and allow each MP to vote according to their consciences as is intended. We acknowledge the diligence with which all Labour and National MPs considered the bill. Whether they voted for or against, they listened and engaged and reflected deeply. but the apparent lack of engagement by the Green and New Zealand First parties with this most serious of issues is what has determined the outcome to this point. And it ended with that, well, not ended, but that paragraph ended with, that's a charade, not a conscience vote. The committee stage, where the bill will be considered clause by clause before a third reading, will be a time-consuming and complex process of considering multiple amendments. The likelihood of mistakes, misunderstandings and muddles is frightening. Every MP now has a personal responsibility for shaping a bill that sets out to cause the death of some of their fellow New Zealanders. It's about to get very real, and all MPs are going to have to explain each and every one of their choices. Lives are at stake. I had the privilege of being in Parliament. It was a hard privilege in that I was saddened by the outcome of the vote, and I was sitting beside the Disability Rights Commissioner, Paula Tesoriero. She has spoken to many MPs on the television within Parliament against this bill, and is very concerned and representing the disability community about their concerns. David Seymour has suggested that he will introduce a supplementary order paper, which I think is ready, in which he'll remove references to people with disability, so that the bill will be narrowed down to people with terminal illnesses, which brings it straight back into the world, unfortunately, of palliative care. In addition to sitting beside Paula Tesoriero during the in the public gallery, I sat beside Claire Freeman and Kylie Black, both of whom, as the picture shows, are young women with significant disabilities who have spoken out against this bill, not just on their own behalf, but on behalf of all people who are vulnerable, identifying that people are vulnerable simply by being sick, and vulnerability, in addition to having a severe disability. The category of vulnerability is huge. I must say that it was very sad to sit beside them because they were quite distressed at the outcome of the vote. The next slide is a picture of about half of the 15 doctors who've written an article recently, and following next slide is details of the article that they've written. And it's in the World Medical Journal, and it's the Journal of the World Medical Association. And the World Medical Association has a statement opposing the involvement of doctors in euthanasia internationally, saying that even if it's legal in a country, it's unethical for a doctor to participate. However, there have been some pressures, for example, from the Canadian representatives on the World Medical Association to change that position statement. So this article, which is accessible on the World Medical Journal by 15 international physicians, geriatricians, palliative medicine doctors, and general physicians, as well as psychiatrists and surgeons, expressing the reasons why the World Medical Association should not change. And the World Medical Association has not changed its position. So some of the points in that article were that euthanasia fundamentally devalues the patient. Euthanasia totally lacks evidence as medical treatment. And why they've referred to that is that now in Canada, euthanasia and assisted suicide have been legal for about 2.5 years. It's now considered a medical treatment and considered a human right. And we'll discuss that again a little bit. These authors in the World Medical Journal write over 3 pages about the risk that it put for patients, and also says the acceptance of euthanasia undermines the boundaries between end-of-life care practice that do not intend death, that's palliative care, withholding and withdrawing life-sustaining therapy, and those that do intend death, which is euthanasia. They say that these weighty moral considerations are supported by the ethical intuition of the global medical community. The World Medical Association's Code of Ethics strongly influenced standards for the practice of medicine around the world, and so they urge the World Medical Association to maintain its opposition. Similarly, next slide, the American Medical Association, which represents 270,000 doctors, in June of this year came out with their statement again. So it was after a heated battle over the last year and a half, and 3 recommendations from their ethics committee to continue to oppose assisted suicide and euthanasia. So they affirmed their position in June, and the vote was 65 to 35, and in their view, a stunningly huge margin of victory. And they now say, permitting physicians, next slide, to engage in assisted suicide would ultimately cause more harm than good. Physician-assisted suicide is fundamentally incompatible with the physician's role as healer, would be difficult or impossible to control, and would pose serious societal risks. Instead of engaging in assisted suicide, physicians must aggressively respond to the needs of patients at the end of life. You may remember, you may have been online when Dr. Leonie Herx presented at a similar forum to today. You may have seen, she's a Canadian physician, a palliative medicine physician, who was explaining to us in New Zealand how it is not working, euthanasia and assisted suicide in Canada, in her view. She spoke on television in New Zealand. There was a debate with David Seymour, Bill English, Claire Freeman, who is the young lady with the disability you've previously seen just now, with the NZNO representative, and with Jack Havel, the retired anaesthetist from Waikato, and that's available online. As you may remember from Leonie Herx's lecture to us, her points were, in summary, that Canada has not got it right. 2.5 years after the introduction, there are expanding eligibility criteria, including no requirement for prognosis. So the suggestion that David Seymour is that the bill will be altered to just involve you have to have a terminal illness with a 6 months prognosis. But from a legal point of view, what's the definition of a terminal illness? And from a legal point of view, how do you determine that someone has a 6 months prognosis? So that's the bill that's being introduced in New Zealand. So to get around that in Canada, because people have said, why 6 months? Why not 12 months? There's no scientific reason for 6 or 12. So they've changed it and got rid of months and just written in that death has to be in the foreseeable future. So that's even broader and more nebulous. So as you may have remembered from Dr. Herx's presentation, she talked about the suggestion in Canada and some papers that have been submitted that it be available for mature minors. That's children or young people of 13, 14 years of age, where the doctor considers that they're mature enough to make decisions. And also in Canada, it's suggested that it be introduced for mental health. In the Netherlands and in Belgium already, and Dr. Mark Comrade, a psychiatrist from the United States, has written and presented extensively about the number of people with psychiatric disorders who are now being euthanized. In addition, Dr. Herx Leonie spoke about the conscience rights of physicians in Canada not being protected. And in Ontario recently, the courts ruled that the doctors had not a right to conscientious objection, and they must provide an effective referral. An effective referral being that you must refer to somebody another doctor or nurse practitioner in Canada, who will actually provide the euthanasia. So for doctors with a conscientious objection based on clinical grounds, or providing an effective referral would be against their conscience. Other things that Dr. Herx wrote about was the forced participation of some publicly funded institutions. So because it's become a medical treatment and because healthcare is nationally funded in Canada, there's pressure on hospices to actually provide this even though they object. Then the lack of adequate data collection in Canada and monitoring and oversight mechanisms, the lack of protection for the vulnerable, and Dr. Leonie presented to us examples of people who, instead of not wanting to go to a rest home or institutionalized care, they were so afraid of that they requested euthanasia. That's just an example of a vulnerability. And she spoke about the impact on medicine and palliative care. There was, in the last few months, and you may have noticed it on television or on posters or in the newspaper, the New Zealand Herald and the Dominion Post prior to that, we collected about 1,170 signatures of doctors just by word of mouth who are concerned about the risk to the vulnerable of introducing this legislation and also the risk to the doctor-patient relationship, and how euthanasia introduces something that will, in our view, of those people who signed up, those doctors, a complete knife through that doctor-patient trust relationship. Not only have the doctors gathered force and spoken out, but also lawyers. And these are the lawyers for vulnerable New Zealanders, and Richard McLeod is a spokesperson. They, and Juana Hickey also in this slide, who has met MPs, spoken in Parliament, been on television and radio. And they are saying the end-of-life choice bill will lead to the victimisation of vulnerable New Zealanders. Although its stated purpose is to offer choice to a small number of suffering people who are not vulnerable, it actually applies to large numbers of highly vulnerable New Zealanders who could find themselves eligible for euthanasia or assisted suicide. A right to die for a few Kiwis could very quickly become a duty to die for many others. The Care Alliance made a series of about 24 videos. You may have seen these online. It involved, you see Claire Freeman there, and also Amanda Landers. It also involved the Palliative Care Nurses New Zealand representatives and general medicine physicians, the disability sector, geriatricians, nurses from mental health. And that was part of a campaign all expressing our concerns about the risks to the vulnerable. In addition, the Pacific community have become concerned, and a Pacific physician in Wellington gathered people together in their communities in the Wellington area. They had a march on Parliament. They asked to meet their local MP locally within their community, and then to meet them in Parliament, but that MP hadn't agreed to meet them. So they're very concerned. They feel they're a vulnerable group at risk. It's contrary to their values as a community. And they have tried to express their concerns and are disappointed with the response from their representatives in Parliament. You perhaps recognise Kate Baddock, a GP and chair of the NZMA, the New Zealand Medical Association, and they have spoken on television as here and in public, and they're saying the same as the World Medical Association. They're holding their position that it's unethical for a doctor to participate even if it's legal, and their biggest concern is the same, the risk to vulnerable people we care for every day. The impracticality on the ground, this bill will not work. It will cause more issues than it certainly would resolve. The next slide is Margaret and Greg Malcolm, and that's their daughter Jane. Jane was a lawyer, and she was 42 years of age, and she had a brain tumour. Very similar details as Lucretia Seals. And just to say, Matt Vickers, Lucretia Seals' husband, was in the gallery for the vote in the second reading on June 26th. Unlike Lucretia Seals and Matt Vickers, the Malcolm family cared for their daughter at home. She was exactly the same age as Lucretia Seals, the same professional background and a brain tumour, but she was cared for supported by the hospice and community services in the Wellington area, and they speak out against the risks of euthanasia and that concept of how people can feel a burden and how they will potentially ask for euthanasia and receive euthanasia because of feeling a burden to others. The next slide, slide 22, is a summary of the arguments against the end-of-life choice bill. To start with, the weight of the Justice Select Committee evidence is overwhelmingly against the bill. So there were 38,707 written submissions. 34,932, that's 90%, were against the bill. Of these, 93% of more than 600 doctors, more than 800 nurses, and more than 500 other healthcare professionals were opposed. So 93% of healthcare professionals were opposed, 90% of 38,000 people in the community were opposed. The bill places vulnerable people at risk. The elderly, those who are depressed, people with disabilities, those with terminal illness. Over 10,000 submissions talked about some aspect of the bill placing vulnerable people at risk. There was expert evidence from family lawyers and frontline caregivers showing that many people are subject to coercion and abuse. It takes a variety of forms and it is very difficult to detect. There was expert evidence that vulnerable people feel a burden on others, concluding that an early death might be best, even though they actually don't want to die. A geriatrician wrote to the Justice Select Committee, elder abuse is common, frequently unreported and perpetrated by someone close. A person with a disability said, I oppose the mentality behind the bill as a disabled person whose life is equally valuable. Euthanasia disrupts the doctor-patient relationship of trust. Administering lethal drugs contradicts why doctors enter medicine, which is to care, not kill. It is totally against the stance of peak bodies in New Zealand, Palliative Care Nurses, Hospice New Zealand, NZMA, and Aotearoa, and it imposes an unethical practice on medical practitioners who overwhelmingly don't want it. Dr. Peter Benny of the British Medical Association, writing to the Justice Select Committee, said, there is no way to guarantee that someone has not been coerced. The College of GPs in New Zealand wrote to the Justice Select Committee, it is impossible for doctors to determine if a patient is free from coercion. Overseas experience is not reassuring. The number of deaths keeps growing. Example, in the Netherlands, it was 2,000 10 years ago, and it's now 6,000 per year of people who are euthanized. In Canada, the total was 6,700 over the first 3 years. The eligibility criteria inevitably broaden because once the principle of state-sanctioned ending of life is established, rights-based arguments for expanded eligibility become irresistible. Many people are choosing euthanasia primarily due to a lack of good care and societal support in adjusting to their chronic or terminal illness. They name relational, societal, and even financial reasons rather than physical reasons such as pain as the main motivators. Next point, the double standard in relation to suicide. Among the greatest concerns expressed in the Justice Select Committee submissions, including from experts, was the double standard in relation to suicide. A South Auckland GP wrote, we are telling youth that suicide is not the answer, and yet saying to our disabled and terminally ill that it is. Those youths that have talked to me about the issue have mentioned the double standard. It is argued that euthanasia will prevent people with terminal illnesses or other grievous and irremediable suffering from taking their own lives, but the evidence does not support that conclusion. If anything, it points to the opposite. Jan Latten of the Dutch Bureau of Statistics, when presenting the Dutch 2017 suicide figures, suggested that even speaking about assisted suicide leads to more death wishes, which in turn exacerbates the underlying suicide rate. Palliative care. There are significant advances, as we all know, in palliative care over the last decade, and it works. While people have experienced hard deaths in the past, most will be much improved with today's knowledge. A doctor writing to the Justice Select Committee said, if the public were educated about real palliative care and experience it to the highest standard, then they would change their minds about wanting assisted suicide. And the last point, choice. The end-of-life choice bill, if passed, will apply not just to a few hard cases, but to everyone in differing contexts and circumstances, resulting in early deaths due to coercion in its various forms. Choices have consequences, and my life, my choice, has the consequence that someone else must be a party to your death. If Parliament creates a moral right for a person to have their life ended, then that creates a moral duty and obligation for someone else to end their life. Individual choices and rights need to be balanced against the common good. Slide 23. Stephanie Green is a doctor, practiced in general practice, I understand, in Canada. She visited New Zealand on the week of the second reading and vote. She presented at the Voluntary Euthanasia Society AGM, and she had an online conversation that you could write in questions. So she's a euthanologist, and that's how she's described. So she moved to practicing as a euthanologist from general practice in Canada. So I just copied some of her answers to the questions. She said that I have the privilege of speaking with 350 people about the issue of assisted dying, and I have personally helped 150 people to end their life. So responding to Anne, she says that every person who qualifies for an assisted death must have a serious illness, disease, or disability. So from my point of view, I thought that was a very broad category and very lightweight in its safeguards. It's just my opinion. Responding to Ron, she said about the process, 99% of all assisted deaths are by clinician-administered IV medication, and the average time is 10 minutes. So although assisted suicide as well as euthanasia are available in Canada, 99% of people are choosing that the doctor will sip aside and inject the medication. So that concurs or fits in with our suggestions that providing this medical cloak of legitimacy kind of obfuscates or clouds what is actually happening, and people actually want the doctor there for reassurance rather than take the medication themselves. So Stephanie Green said, I have to tell you, this is some of the most rewarding work I have ever done. Overall, I feel very good about my work. She was responding to Mary, and she said, it still surprises me that there are a great number of Canadians that don't know that this is legal. So she feels strongly that in the appropriate circumstances, so this is slide 24, when a patient may be eligible for this care and may be unaware of it, it is extremely important the clinician raises this as an end-of-life care option. To not do so means the patient is not able to give true informed consent to any choice, and I would consider that unprofessional conduct. So she's suggesting that if you get a diagnosis of, heart failure, and you're told what the options are for treatment, or kidney failure, or a form of cancer, at the time of the diagnosis and being told, you should be told that this is an option, that euthanasia and assisted suicide, and to not do so would be unprofessional conduct. And that she's suggesting, and in further documents it suggested, that all healthcare professionals should take this on as a responsibility. Stephanie Green saying, any practitioner that wishes not to be involved in MAID should be supported and respected for that decision. However, in a country with universal health care, Canada and New Zealand, with publicly funded institutions, which is Canada and New Zealand, facilities probably do not have the same rights as an individual. However, it is happening, which is leading to forced transfers, which I think are cruel. So she's referring to the fact that some hospices in Canada were saying they wouldn't participate, and the patients need to be transferred out of that unit to somewhere else for the euthanasia, and that this is a forced transfer, which she thought was cruel. But I suppose the reality is, and Dr. Herx referred to it, that from hospices, people are frequently going to the hospital for assessment, for a CT scan, for an MRI, for spinal intervention, an anaesthetic intervention. They're being moved perhaps home. So transfers are happening all the time from the hospice. So to consider it a forced transfer it's a different view than perhaps some of us would have. She then refers to the official Health Canada report suggesting just under 7,000 people have accessed, but she thinks it's actually 8,000. And the reason is uncertainty is that the data is not being well collected. She says, she's responding to Lydia, in Canada, anyone who consistently objects to providing this care, and she describes it as care, may do so, however, they may not abandon their patients. So they must notify the patient they're objecting, and they must make an effective referral to an available clinician. So for many of us doctors and who have believed that not on a clinical grounds this isn't appropriate, why would we make an effective referral, a referral to someone who will actually carry out the euthanasia for this patient whom we care about? So she's responding to Paul, saying that in relation to coercion, she takes all the elements of the responsibility very seriously. I'm trained to take extra care with this particular criteria. But that's not, in the World Medical Association, the American Medical Association, the NZMA, they're all saying it's very difficult to detect coercion. We're not trained in it. It's not what we're meant to do, and vulnerable people are at risk. Refers to what I've just mentioned, the Canadian Association of MAID, Medical Assistant in Dying Assessors and Providers. This document was prepared by ethicists and doctors and nurse practitioners, and 2 medical students signed this document, so they worked on it. And it's about bringing up MAID as a clinical care option. So they're suggesting that all healthcare professionals should take responsibility to tell the patient at the time of a serious diagnosis that this is available. So not just wait for a patient to bring it up themselves. And they recommend that the patient should also understand that your objection as a healthcare professional is moral and not due to clinical reasons. So for many of us, it's based on clinical grounds. Dr. Frank Brennan is, this is slide 29, this was published last week. It's available in the Internal Medicine Journal of the Royal Australasian College of Physicians. Frank Brennan, as many of you will know, is a lawyer and a palliative medicine physician in Sydney in Australia. And his editorial, I think, is meant to coincide with the coming into effect of the legislation in Victoria on the 15th of June for euthanasia and assisted suicide. So I recommend this article to you, and I'm going to go through it in a little bit of detail because of what I think the beautiful way that Frank has written this. From the very public domain of the Parliament and the press. So remember that he's writing this following the enactment or the introduction and the starting of it in Victoria, a state in Australia. The human drama now moves into an intensely private space, the encounter of a patient with a doctor. Founding that encounter is the law. Experiencing that encounter are the individuals themselves. Law aims for precision. Medicine, on the other hand, operates in a landscape of uncertainty. So when the two disciplines meet to focus on issues vital to euthanasia legislation, there may be problems. Those issues include the prognostication of illness, decision-making capacity, screening for depression, the possibility of undue influence. As physicians, we know we cannot be certain about these issues. The laws strain to achieve certainty in language and effect. The law seeks, but medicine cannot provide such certainty. And yet with euthanasia, both disciplines must be highly conscious of the irreversible consequences for not getting things right. There is therefore an inherent tension at the centre of any euthanasia law, for law is entering the domain of not only medical uncertainty, but also the mystery of the human psyche and interpersonal relationships. Uncertainty and mystery are not solid foundations for any legal statute. All euthanasia laws face a series of identical challenges. Those challenges are significant and arguably insuperable. Challenges include the criteria of eligibility, prognostication, the assessment of capacity, ensuring the person is not acting under undue influence, the role of doctors, nurses and pharmacists in the process, the role, if any, of palliative medicine and psychiatry, and the structure of the process leading up to the final act. Flowing from that are the medical questions that pour out upon this landscape to make this exquisitely vexed area even more problematic for doctors. In Victoria, under the Act, neither a referral to nor assessment by palliative medicine is mandatory. Logically, this leads to a basic question. How can one make a decision as fatally serious as this one without being fully informed about the very discipline of medicine that is dedicated to the management of life-limiting illnesses? Simply stating the existence of the discipline, that's palliative medicine, or palliative care, does not explain it. It is ironic that a campaign that trumpeted autonomy and the power of choice may lead to a situation where a person is insufficiently informed in their decision-making. Information is one thing, experience is another. In the Victorian Act, one of the criteria of eligibility is the subjective intolerability of suffering. In reality, this is often the point where palliative care enters the scene now. It does so to bring a powerful and forensic approach to these issues and their management, being attentive to and understanding of the rhythms of both the disease and the human spirit. Instead, under the Act, the eligible person embarks on an altogether different journey. Process dominates. Seeing a palliative care physician is optional. The patient decides on the point when things are intolerable, but that decision may never have been informed by the actual experience of receiving palliative care. Moral distress of health professionals. He continues to write, "We may never know the emotions of those health professionals involved in this process, the misgivings and moral distress they may experience. For however brilliant the law that is crafted, no law can ever know the heart of a person. 1,000 legislative safeguards will never ensure their emotional peace." Medicine and the response to suffering. No law, and perhaps especially no law on this topic, can hope to encompass the limitless terrain of the human person and their world in times of serious illness and the medical uncertainties that accompany this. Physicians struggle daily to deal with this. The law is no exception. Each of these challenges is substantial. Each of these questions represents the sheer complexity of a legally prescribed process that now sits in a domain that is already challenging and mysterious. The profoundly human experience of becoming seriously ill, balancing hope and realism, enduring and hopefully overcoming symptoms, facing one's own mortality, gazing with penetrating eyes at the meaning of your life, comforted and comforting. No law can use this language, and yet that is the reality of our work as palliative care physicians and nurses. Discussion, negotiation, compromise, and there lies the rub. Law grapples earnestly with this area and seeks to marshal multiple safeguards in the process leading to euthanasia. But by having as its destination the planned premature death of a person, the law ventures into an uncertain medical terrain, the vagaries of human nature and the extraordinarily complex nature of interpersonal relationships. No law can perfectly capture this reality of minds made up and then changed, of the ebb and flow of the human spirit, despairing now, content a day later, of a selfless impulse in some to ease the burden on one's family, of a lifetime habit in others of acquiescing to the suggestion, even unspoken, of a dominant relative. In addition to this struggle, the legalization of euthanasia does another thing that is striking in both intent and effect. By such statutes, the law crowns autonomy king. Every euthanasia law starts and finishes with the express wish of the eligible person. Every physician knows that we cannot give everything a patient wants or insists on. We know that autonomy, however revered, is one of several guiding principles. And while we listen to patients, our responsibility is always to weigh carefully the benefits and burdens of treatment. So if, in this one area of medicine, autonomy trumps all else, where that supremacy is legally sanctioned over and above other principles, then there is a problem for law, medicine, and ethics. By the present law, the we in all of us is subsumed by the I in some of us. The I is placed pedestal high, such that it purports to oversee death itself, and the dangers inherent in that coronation are ignored or set aside. Kia kaha. While we in the Care Alliance have been struggling and achieving a lot in presenting what we consider to be the risks to New Zealand society as a whole. John Kleinsman, who you may know, who's the chair of the Care Alliance, his father was dying, and his father died about 2 weeks before the second reading. And so I'm going to end with the eulogy or the commentary that he made about his father at his funeral. And in it, for me, it sums up what we're all trying to achieve in the world of palliative care in New Zealand, and also the vulnerability of people we care for and serve. Dad died at home with family present, very peacefully, on Sunday afternoon. It was a good death, a gentle death for which we are all grateful. What can I say about him at a time like this? There is much that can be said, and yet there is nothing that can be said that can adequately do justice to who Dad was. So as Dad's physical mobility declined, and then his physical strength, he struggled with the idea of being a burden on others, of being useless. "Don't waste your time on me," he would say, "because you're far too busy." It was easier for him to show love and give care than receive it. Things came to a head for Dad about 4 weeks ago, one night when he still wanted to toilet himself, and he couldn't anymore. I could see that, but he couldn't. He pushed me away. He was extremely angry. It was a turning point, a tough moment for both of us and also for my brother Mark. But what happened after that was lovely. He came to accept that this is how things were and graciously allowed us and the wonderful district nursing team, supported by Mary Potter Hospice, to care for him. He allowed us to give to him, and he was so gracious in receiving it. Thank you, he would say, no matter what needed to be done. It strikes me that this is the challenge that goes to the heart of the spiritual journey that we are each called to embark on. Firstly, giving love, but not just giving it, also receiving it. Accepting that we are not in control. Accepting that our lives are a gift. Letting go and celebrating receiving the gift of love given generously and tenderly. No closing remarks. Thank you very much for listening. Kia kaha, and as I've said on the last slide, now is the time. This is our time. We're the people and we have a voice and we care for each other, and I believe we shall overcome this huge challenge and for the sake of the people we care for and serve. Thank you.
Thank you. On behalf of Hospice New Zealand and the registered sites, we would like to thank Dr. Donnelly for sharing her time and knowledge with us this morning. Thank you, everyone, for listening today. We hope you have found this lecture interesting and informative. Have a lovely day.